All right. Well, thank you all for joining me this afternoon. We just had another panel that I was honored to be a part of where we talked about some of the clinical issues with primary progressive aphasia, but we understand that at this conference that we're representing people who have primary progressive aphasia and other frontotemporal dementias, all which impact communication. And so I am a speech pathologist. My name is Maura Silverman. I am a speech pathologist, and for those of you who came from the other one, you'll know that I kind of had it with the traditional medical model in speech pathology, and understood that it wasn't the insurance company's job to tell me how long I should see somebody who had aphasia, that maybe it was up to the person and their family to determine that. Imagine that. So what I did was I quit my job and started a program called the Triangle Aphasia Project. I bring that up only to say that the things that I am saying I understand are in the world of no insurance, and that I can do what I want to do because I developed the programs to be that way. But I think in reality, it's important for this group to know that is because if something doesn't exist, it doesn't mean you can't create it. It's got to answer the problems and the situations that you're having right now. So we will be talking about all different types of communication tools that have come out of just experiences. So your experiences are going to be different than mine and from the people that I have served so far. So one of the things I was hoping was if I get through some of the communication tools and Teams information, is that we can also look at what are some of the problems that you're having in regards to communication, and where could we get creative in terms of coming up with tools to still have a person engage and connect with another human being. So we'll get straight to it, and so that also means that you don't have to hold all of your questions. If you have ideas or thoughts that you want to ask me, go ahead, but we'll definitely save room to do some of that at the end. Okay, so the objective of this program here is to remind us and to tell the world, as we were talking about in the last session about talking about the big elephant in the room, which is aphasia or communication challenges, is that just because you have a communication challenge or PPA doesn't mean you don't have something to say. It doesn't mean you don't have something to contribute. It just means the access to the ability to do that through things that we're used to doing it through, which is speech and writing and reading, is impaired. And so we need to find ways to develop some new ways to communicate with a person who has challenges in these areas, and to develop confidence in the ability to do that no matter who the communicative partner is going to be. Okay? I do that basically by asking people what's frustrating about the communication challenge? What do you wish could happen? So let's start where we should start, which is what is communication? And if you look in, the dictionary, you're going to find that when you talk about communication, we're talking about transactions. So me going to the bank and asking for $50 and them laughing and saying, you run a nonprofit, you don't have $50. No, like transaction is just getting something done, asking for your medication. One of the frustrating things to me is when we simplify everything to be transaction, where because somebody with aphasia is trying to express something, are you sick? Do you have to go to the bathroom? Do you have a headache? It automatically goes to our bowels. I don't know why, but it just automatically the discussion is that something is wrong. People might not be thinking that. You're not thinking that right now. You're not thinking that during lunch. You were thinking about, how cute it was that the dog barked every time somebody clapped. Or I wonder, what my dog is doing. I hope he's not into the garbage. Or it's the thoughts and the ideas and all of that that we've got to somehow get to. And then it's interaction. It's ability to connect with other human beings. So communication goes beyond just transactions and actually is how we connect with other human beings. And it doesn't matter what modality. Think of all the different ways you've communicated so far this morning. Anyone receive or send a text? Anyone receive or send an email? Has somebody called and checked on anybody? There are so many ways. Did you introduce yourself to somebody? Did you share a story with somebody? So all of those ways that we can communicate are important. And where one doesn't work, maybe we can get another one to work. To do a talk on communication impairment, you would have to get a master's in speech pathology. That's a little 2-year long. We're going to make that 2 minutes and say that there are many types of neurological impairments that affect communication. But I think it's important that we really kind of qualify what is what. So when you think about impairment in communication, you could be talking about speech. Okay? Have you ever talked to somebody or known somebody her speech, we're trying to produce speech? I'm really good at making every type of speech disorder, so that is called dysarthria. A lot of times people will say it sounds like they're drunk, or it affects some level of the motor speech area, from the breathing to the voicing to the nasality. So if somebody has ALS or Parkinson's or some type of neurological impairment, a stroke, they could have dysarthria. Another more complicated speech impairment is called apraxia. And that is a little bit harder to understand, but it's basically the motor plan leaving the brain from your frontal lobe, from the motor strip, and saying, this is how you produce that sound. And then your muscles work fine, so you don't have weakness or incoordination here, but something gets missed along the way. One of my physician friends said, it's kind of like you have one of those lamps in your house that the bulb works and the outlet works, but then you have to kind of shimmy the cord a little bit. Well, you probably should get rid of that because it's a fire hazard, but other than that, that's what apraxia is. So sometimes it comes out great, sometimes it doesn't come out at all. So it's a motor programming problem. It's very different than having aphasia, but the problem is you can have aphasia and you can have apraxia, or you can have aphasia and you can have dysarthria. Aphasia is a language impairment, okay? Can we separate language from cognition? No, not completely. But for this purpose, it is important to kind of pull out what is what. Because aphasia affects language, which is 4 modalities: reading, writing, listening, and speaking. If you want to learn a new language, you want to learn Italian, okay, you would have to be able to speak it, you'd be able to read it, you'd have to write it, and you'd have to be able to understand when people are talking to you. When people have aphasia, they can have deficits in each of these areas. So as the doctor that was on our panel explained to us, is that you have all of these different subtypes of PPA. You can label them as that. We could do the same thing if someone's had a stroke. They have global aphasia, they have Wernicke's aphasia, they have Broca's aphasia. Let's put it this way. They have trouble with reading, writing, listening, and speaking, but they have strengths in each of those areas as well. So just because someone can't say something, they may be able to still write it. Just because they aren't able to understand what you're saying to them, if you use a gesture or you write it and write key words, they might actually be able to do it much better. So thinking of aphasia as you've had this file system in your brain and all those words are organized in your brain, and then it gets tipped upside down. And the files are kind of all over the place. It is the expansion of the senior moment where you know what you want to say, but you can't get it out. It's the tip of the tongue syndrome, but a lot and often. The cognitive deficits, again, you can't separate language from cognition, but when you have cognitive problems, you have problems in the thinking piece of it. So the organization of the information you're getting in is either overwhelming, it affects attention and memory, it affects problem solving. In our population that we're talking about today, it affects the ability to sequence and organize tasks that seem really just kind of natural, something we've done for a long time. So executive functioning, you've heard. My mother, who unfortunately had a stroke, was way up in the front, so she has some frontal challenges. And she'll put her hands under in the sink. There's no water on, but she's got soap on her hands. And then she'll reach for the towel. You think, you're missing something here. Or how it affects her aphasia is she'll go to tell me something she needs, and even though she could easily use a gesture to show me, she will keep trying to say it and doesn't abandon one technique to use another technique. So we have to kind of be the ones to facilitate the change of those techniques. So while I could talk about the disorders themselves, what I'd rather do is tell you how we can make a better difference, because there are huge consequences to communication impairment. And I'll tell you, the ones on the left side, which are really something that I've just become very passionate about. I feel like having my mom being in a nursing home and watching this healthcare disparity is putting disparities on a whole new level. We think about economic disparities and racial disparities, but if you cannot communicate your needs, guess who's the last one to get fed? The last one to go to take care of for the bathroom? I mean, I hate to tell you, but those people that are communicatively vulnerable are at much higher risk of disparities. There's research to show that 60% of all medical errors in a hospital is because of communication challenges. How many falls are related that somebody wanted to communicate something that they had to go to the bathroom? Here we go back to bowels. But they needed to do something and they couldn't get that message across. And then the tie-in to depression and mood that we are not paying attention to near enough. But also the personal changes that happen and the issues that result from communication impairment. Whether it is a slow, insidious kind of approach to losing your language, or a stroke or a brain tumor, or something that happens more acutely, a person with aphasia or difficulty communicating, their roles change. And everything changes about interaction and connection with that person. Sitting at a table at Thanksgiving with my mother, it takes forced effort for the kids in my family, my very self-absorbed teenage-ish young adult men, to think not of themselves, but how can I ask grandma a question to get her involved in this conversation, because she will literally sit there and not say a word or not interact. So the change in the roles is the biggest thing, and it is one that I really want to talk about today. How do we find out what those consequences are? Well, this was just a recent program that I went to there was a conference at Aphasia Access, our leadership summit, just a month ago up in Baltimore. And there was an article that a couple speech pathologists and some people with primary progressive aphasia got together and published in the Journal of Humanities in Rehab. And this is actually an open source article, so anybody can get it. But it was called 3 Voices at a Table. And one of the really cool things about this article was it looked for, you know, what do people want to know about PPA, and what do we want to make sure that we're paying attention to? And there was many findings, but some of the big insights that I pulled away from is that there has to be a way of balancing life and enjoying your life at the same time as you plan for the losses. So we've heard this a couple times today, right? Is living life with aphasia and with challenges in communication. And then the families were saying, if something is curative therapy, like something that they design for aphasia for stroke, can I still be included in that even though I have PPA? And I will tell you that the latest research is showing that if you treat PPA, and aphasia particularly, with some of the traditional aphasia therapies, that not only will people not get worse as fast, but they will actually improve in some areas in naming and such. So we're finding some outcome measures that are showing that curative therapy really does have a place. My bigger piece is, if you know something's coming at you, why don't you try to do everything you can to kind of keep it at bay? And we'll talk about this, but it's not habilitation or rehabilitation. It's compensating and trying to keep that moving train from coming at us. And then the other thing that they really expressed in this was, guess what? We're not in relationships just with the person that we married or our sibling that's taking care of us. We spend so much time in the professional world training one person, training just the person who brings them to the appointment. Makes no sense. The person that has a communication challenges has have changes in all of their communicative partners, all of their communication environments. So it's important that we do that. So at TAP, we asked our folks, what do the people with PPA want? What does a person with aphasia want? And one of the first things they said is, I just want to be acknowledged for the cognitive and communicative aspects that are still there. The cognitive and language competencies that are there. Why do you think that people with PPA are, for the most part, willing to hand somebody that card? What are they really communicating to you when they hand you a card that says, I have aphasia? Please be patient with me. What do you guys think they're trying to say? I'm sorry? Yeah, they want to be included. They want you to pay attention to them. They want you to know their thoughts are still valid and that they still want to be engaged in this conversation, or they wouldn't share that information. They want to be included in all life decisions, all healthcare options, all social opportunities, and most important, conversation. I don't know why I put animate there, so that's really odd. That showed up on that slide. What that means is, yes, having definite discussions about any of these things are hard when you have good communication. It's already hard. But if the person has poor communication, then you need to provide some supports to allow them to participate in those decisions. And again, if nothing exists, you got to create something for them. So I remember I did a lot of work with the Brain Tumor Center at Duke, and you know, several of those people, a good majority, will end up passing away and had to make decisions about continuation of treatment or not. There was nothing that allowed anybody who with aphasia and a brain tumor to express to their doctor that yes, they were done doing treatment, or no, I don't want to go to this, or yes, I would like to have full resuscitation and try another clinical trial. So we just made them up. We drew pictures and we got pictographs like the ones I was telling you about. We just get pictures of people doing things. Thank God for Google now. We have like images that we can take pictures and put big red circles over and have people choose with a nonverbal choice. And we also have the ability to verify. And that's what I'm going to teach you today, is really how to do that communication. And then also for the help that we do receive, people with aphasia will say, I like getting help. I also like to be asked if I would like help, first of all. You know, I don't want you just to jump in. Most people with aphasia will say, don't just fill in for me. Ask me if I would like help. But then when I do ask for help, make sure it's relevant, make sure it's salient, and that it's provided without judgment. I hate to even have to say that, but I remember, and every time I have a consultation with anybody who has aphasia, they will say something to the effect of, I don't want to see another worksheet. Why does the speech therapist keep handing me these things that I did in kindergarten? Why, just because I'm having communication challenges, do I have to practice writing dog, pen? You know, those aren't things that you communicate about. And last time I knew, I didn't go in a room and go, table, microphone, ceiling. You know, that's not what people want to be able to do better. So then we said, well, what does the communicative partner want? And again, I'm talking about one communicative partner? No, I'm talking about anybody that interacts with a person with aphasia. They overwhelmingly say that they want to be helpful. They want to do the right thing by providing cues. And as I said in the last thing, you don't want to throw the baby away with the bathwater. You don't want to give them everything if they only need a little help. But we love the person, and watching them struggle is awful. Watching your husband struggle is awful, right? Watching my mom, who gave me life advice, was there for me in the worst times in the world, and she looks at me and goes, and I know what she wants to say. How cruel does it feel to sit there and not fill in for them? What you have to think about is if somebody's losing their motor function and they were walking in this room and they were taking their time and they were going slow and they were using a walker, would I ever go and pick up that person and carry them to the bathroom? Of course not. It wouldn't even be a thought in my head, because I would be thinking, they need that. You know, intuitively, I know that the muscles have to keep, you know, got to keep using it. Use it or you lose it. But with communication, it's different. We feel a responsibility and we feel like we need to jump in, and it's really hard. They also want to be recognized for the assistance that they can and do provide. I think people that love somebody with aphasia or other communication challenges just want to know that others feel that they're doing the best they can, because it ain't easy. It's really not easy. I've been doing this for, okay, did I color my hair? Yeah, 30 years. Just trying to see how obvious it was that, I don't know why my mom has white hair and I'm just still dark. I don't get, but I've been doing it a long time. But it seems that sometimes when you watch somebody struggle, that all the stuff you learn just goes out the window. So give yourself a break. Give yourself a little grace. And then they want to have access to tools that aren't so cumbersome and complicated. It doesn't have to be a fancy, there's some great communication systems out there. But for PPA and for aphasia, it's generally not necessary. You can use much more simple, low-tech things than getting some big expensive device. As a matter of fact, I have a lot of $8,000 plus pieces of equipment gathering dust on my shelves because families have bought them thinking that was the answer for that person to be able to communicate, and it clearly was not. And then they want to make sure that communicative partners all offer aid with respect and dignity. Okay? So basically, we all want the same thing, right? We want to be able to share the communicative burden. We don't want the communication burden on them, and they don't want it just on us either, which is nice. People want to have meaningful exchanges, and we want to have mutual dignity. So we want the same thing, and we're not the only one, because the World Health Organization, which basically monitors all of the stuff that we do in this country regarding healthcare, shows this in their model of care. And what it basically says is that we should not be looking at the impairment that somebody has, but that we have to look at how that impairment impacts their activities and their level of participation. Because that's what living successfully with any disorder is all about, right? And so it offers the fact that what life experiences could we include that would facilitate the use of language. That's really all we're trying to do, is how do we engage somebody in meaningful life experiences? And a lot of that bears down to conversation. In my world, in speech pathology, we call it the life participation approach. And this morning when we were listening, I love being at the end of the day because I learned so much that I can then wish I could redo my slides and throw in. And I thought it was really interesting that when, and I don't remember who was telling us about this morning, was a program, and it was actually, the acronym was TAP, which I thought was really funny, was Tailor Activities to Maintain Participation. It was an OT program. And then the DEMA, which was Daily Engagement, which was a nurse-led. It's all about saying that what the final goal is to have people engage in their life as fully as they want to and to participate for as long as they choose to. And to understand that aphasia doesn't just impact the person, it affects everybody. What I kind of measure it to is that we used to look at an individual, whether they had a stroke or a brain injury or PPA, and we would see all the stuff that was wrong with them. And that's why it was interesting. We were talking in the last session about testing and who determines a person has PPA. How many people in this room have ever had a neuropsychological evaluation? Okay. How many people have ever, or how many people have had a speech pathology battery of tests? Okay. How did those make you feel about yourself? Okay. Just from the laughter. They're awful, right? They make you feel like you don't have any skills left. Because no matter how good you feel about yourself, somebody could go, oh, I love your outfit, blah, 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 but you have, something on your face. You're never going to remember the compliment. You're only going to remember that you had something on your face. Well, the problem with the testing that neuropsychologists and speech pathologists, and I'm right in there with them, do, is that every one of us needs to reach a ceiling. Okay? They're standardized tests so that we can tell the insurance company, or that we can tell you in 6 months how you're doing compared to what you were doing last time, is that we have to reach a ceiling. If you already know neuropsych testing, you already know what I'm going to say here. And then every test starts with a basal. A basal means that this is the easiest level. The ceiling is the hardest level. Okay? So you're going along, taking a test, and they're saying, remember these 5 words, remember these 5 words, or name this or name that, or whatever the test is. And then you start to fail. And right about here, you go, oof, I am not remembering these words, or I am not. And you could be the smartest person on the planet, but they're standardized, so everyone's going to fail. They have to, or it wouldn't be a standardized test. Then you have to fail 8 consecutive times for some tests before they can stop the test. Well, like Murphy's Law, you probably get to 7, so you failed 7 times in a row, and then you get one right. You just score. Guess what? You have to restart those 8 that were wrong. My point being is that nothing makes you feel worse than having something negative pointed out over and over again. And this is what we used to see life as for people. Now we really aren't. We're stepping back and we're using more of a PT-OT recreational therapy model where we're saying, who is this person? What do they love to do? What is their identity? If you haven't looked at anything lately that's been on identity work, it's fascinating of how, like if somebody came up to me in the hall and said, hi, my name is so-and-so, who are you? I'd say, well, my name is Maura and I'm a speech pathologist. I also am a mom and I have 4 boys and I'm a caretaker to my mom. And I started to realize those are my identity. That's how I define myself. Now all of a sudden all those things are changed, your identity changes. And so we need to look at those things to plan what we're going to do with somebody. So then we learn from our intake that somebody wants to do gardening or somebody loves, working with children. Maybe the person was a teacher before they had to retire. Does that mean you sit and watch TV for the next, 30 years of your life? I hope not. You're going to live your life. So you want to find those passions, and then you want to say, how can I find tasks that that person does that still fits in that realm? Okay? And then make those the programs that you do. But then what challenges can we expect from them? Okay? If you look at cooking, for example. Well, I love to cook, but I don't do it anymore. Now my spouse does it all. Why? The why is the answer to what's broken. So somebody says, well, I can't because I can't read recipes anymore. Or my folks will always say, the stroke patients will say, I can't because of my, right hand. And I'm like, oh, lucky I know a lot of one-handed cooking tools, so we're going to be fine. Okay? You can't put away your passions that you love doing if you could instead adapt them or change them a little bit so that they're functional. What about, if you wanted to be involved in your church or in a choir, but you have some challenges? Well, maybe you could belong at a different level. You could work as, doing at a volunteer capacity, or that you have a communicative buddy that you go with to still do the thing. So I urge you, even if you're not, if you're just listening to this as a communicative partner and you're not working with a speech therapist, write down all those things that, are unique to the person that you love, and then say, how can I still get them involved in that without having to give it up completely? So what you're looking for is, what are the barriers? What's stopping them? And once you know what's stopping them, you have some opportunities to realize, how can we make it easier? Now, in rehab, we often talk about you have to make a choice on whether you give somebody a tool to compensate for what they don't have, or you try to work on getting it better. Well, I look at that as one of these highways, okay, is where the dotted line's in the middle. What does that mean when you're driving? See how good your DMV skills are. Yes, you can go back and forth. There's not a choice you have to make. Sometimes you'll need a compensatory strategy. Other times you won't. Sometimes when you go out to a restaurant, you can order yourself by pointing to what you want. Other times you need your spouse to order for you. It's okay. But don't just abandon all language-based activities, because we know then that they'll go away. Big consideration here is that as much as I love my field and I think speech pathologists rock, we're not the end all to be all. You know, we're good. We're not that good. Because life is therapy. Therapy is not your life. So many people will say, oh, I tried speech therapy, but then they discharged me. So, and even worse, if they told you that's the most improvement you're going to make, that's the worst, because number one, I don't think anyone else is christened God, so I don't think they have the ability to say that. But second of all, we listen to professionals. And all they're doing is telling you something that makes them feel uncomfortable because they're no longer able to see you based on insurance. So be very careful to know that we sometimes just don't know what to say. I use this slide in the other presentation because I think when you work with somebody, you have to make sure it's something that's important, but that it's also something that is interesting to people. I have this picture of my mom, and I understand that she had a stroke, but her stroke was so frontal, I feel like she kind of falls into some of these things. But when she was working in occupational therapy very soon after her stroke, the occupational therapist had her taking nails and screws and putting them in these little cups because she had very poor right movement. And I walked in, and literally my mom was asleep. I mean, like, drool, sleep. So getting back to her for waking me up when I was a teenager, I went and got a cold rag and said, Mom, what's going on? You look so tired. And I washed her face off, and I said, what's going on? The OT said, we're working on fine motor, but your mom's not being very compliant, and so we're going to return her to her room. Well, I've worked in rehab for 30 years. My first thought is they're going to go up and write in her chart that she's non-compliant. Guess how quickly her rehab stay is over? She can't tolerate 3 hours, there she's going to be gone. So what I said to her was, look, I appreciate that you want the arm to work, but my mother has never touched a nail or a screw in her whole life. She's a retired nurse. Give her a needle, she'll go poking people with it. But my dad took care of the nails and screws in the house. Give her something that means something to her. And so my mom was raised Catholic, is still very, very Catholic, and said the rosary once a day, twice if I told her I had a headache. So she always had beads in her hand. I put those beads in her hand after I washed her face off, and you could see the muscles. I mean, don't tell me those pathways weren't still there. It's just that this had saliency, which is why that article that I was talking about and the other one from Kleiman Jones about neuroplasticity, one of their #1 things is if it doesn't have saliency, your brain doesn't remember it. How many times have you been introduced to somebody or given a figure of some kind and you don't remember it 2 seconds later? But if they said, if you remember this, you're going to win $1 million, you might find some motivation to remember it, right? So besides moving those rosary beads, she also was the first time she talked because she could pray, because praying is very automatic, and people with communication challenges do better with automatics. So singing, music, and prayer were really helpful. I would say that the focus should not be just on the tools of therapy, but on conversation. I remember a young speech therapist coming up to me and going, so I was working with somebody, but we were chatting so long in the beginning, it was like 10 minutes, so I told him we got to get to work. And I thought, that's kind of the work. Our goal is for someone to be able to converse and have conversation. So make sure that the focus when you're communicating with someone you love with aphasia is on conversation, is on real life stuff. Okay? So I kind of flipped the script a little bit and did tools before teams because it seemed to fit better with what I was talking about. But there's a lot of tools. None of them are rocket science. They're all kind of super easy, and it's something that you can learn. First thing it does is it equals out the playing field. So it allows us to have a conversation with somebody where you're not creating the burden of the communication, okay? So what are some of the tools? Well, every person that, if you're talking to someone who has any type of communication challenge, you should have a piece of paper and a marker. This might be a little big for your purse, but you could get a small notebook. You can use one of those boogie boards that they sell at what is that store that sells all those cool thing that I can't remember the Walmart. Might be Walmart or Staples, is where you write something and then you push the button and it goes away. Those work fine. You can use dry erase boards as well, but my only recommendation is that a clipboard or a notebook with lots of paper is better, because once you've had a conversation, you might need to go back and verify and have more conversation, and if you've erased it, it's a little challenging there. Use scales. I'm constantly asking somebody, you know, how they feel about something. Well, how do they measure that? Measure it with a Likert scale. And all a Likert scale is you see them in the doctor when the pain, you know, is it this or is it that? You know, how badly do you want to do this or do that? These can be just used. They don't even have numbers on it. Most people can just put a line. Use little communication books. You know, you can make these out of brag books. They're $1 at the dollar store or Walmart, and put in not just pictures. This one shows pictures of things, but again, I'm not a big labeler. I'd rather have them more conceptual. So my morning routine is in there. You know, my places I like to go shop, places I like to go eat are in there. And then what I normally order is also in there. So imagine having a little book like that, and I'm going to Wendy's, and it says I want a cheeseburger and French fries and a Diet Coke, and the person doesn't have to have you order for them because that's written down. Low tech, easy peasy. Don't have a conversation about a vacation you're taking or a trip you're taking without using a map. And now, thanks to, you know, this little device, we do not have to go to AAA and get our triptych and our big maps. Every time I have a conversation with somebody about places, I just open the maps. You go like this. Even somebody who's nonverbal can often show you exactly where they grew up, where they moved to, just by using the Maps app on your phone. So those are just some examples of tools. I'm going to give you some more. The other thing is that there's so, again, a little bit higher than low tech. There are things that are already available on your phone. I think that in the last one, that one of the panelists showed how she talks into Siri and has Siri do stuff for her. You know, that's a great way of doing it. There's text to speech. There's a quick, simple adaptation you can do to your phone on settings. If you go to settings and go to general, there's one that's called, and this is iPhones particularly, but all of them have it, is under accessibility. There's larger fonts, there's text to speech. When I get a text, I can touch this and say,
back in room for an hour to relax and put feet up. Head out around 3:30-ish.
Using text to speech allows me to understand what someone's saying better because I'm using two modalities. Remember the reading, writing, listening, and speaking? The more modalities you use, the better. So doing text to speech helps people hold on to reading abilities and spelling. That little one in the corner is called a digital reader. When somebody loves to read, but because of PPA or challenges in communication are having difficulty reading, you can get that from any library for the blind or disability statewide for free. And you can download books from the library onto a USB drive, stick it in the side, and listen. What I love about those versus books on tape is you can change the rate to go really slower so that processing is better. And then you can use a book at the same time. Use Skype, FaceTime, Zoom, anything where there's more visual cues. So when my mom has a conversation with my niece on the phone, it's horrible. It just breaks down. If she FaceTime, she has stuff to talk about. She can see her and ask her questions. And sometimes we'll prepare for those conversations. Well, most of the time, because I'm a nerdy speech therapist, is we prepare for those conversations. So I actually have a little booklet that says when my mom calls her best friend Alice, these are some of the cues that helps her have a conversation with Alice. These are Alice's kids. These are what Alice's kids are doing. These are Alice's grandkids. And this is what was going on last time she talked to her. And we just keep a binder. And every time we have a conversation with her, we cross off the last thing and we write what's new with them. It's kind of like your hairdresser does, and they say, how was that party you went to? And you're like, how did you know I went to a party? Like, I wrote it down when you left. So a lot of this is just preparing and supporting tools. I'm going to give you an embarrassingly true story, is again about my dear mom, who I think I really related to Martha's story this morning in her keynote and said, you know, my mom is the definition of perseverance, but she also is very generous. And in generosity, she gave me this recovery and this journey for so many examples. So I honor her for allowing me. But when my mom had her stroke, one of the things that was very important to her is that she maintained her dignity and maintained who she is, her identity. And that woman never left the house with without a scarf on, her hair done, earrings, makeup. It was part of her identity. I walked into her room one day, and she had a black shirt on with navy blue pants. Oh, my God, that was like wearing white after Labor Day. I mean, her face, she just looked at me, and I said, ooh, that's quite the look you got going on there. Because she went, Maura, like this. And I just saw how that was affecting her whole day. Her mood, her happiness, her ability to feel good about herself was based that she was wearing this ridiculous combination of clothing. And I said, Mom, why don't you just pick out your own clothes? And she looked at me, and with a lot of attitude, she said, I can't. Well, at TAP, I have a rule, you can't say I can't. So I said, Mom, you owe me $1 now. Thank you very much. And she said, Maura, I can't. And she pointed to her closet. And just like any small facility room, there are 2 beds, 2 closets. And when the door opened, it hit the end of her bed. So she literally could not get to her closet to pick out her own clothes. And so I was like, oh my God, I'm horrified that I'm a speech therapist who works on cues and tools and strategies to communicate, and I missed this. And you've been dressing like crazy woman for months now. So I grabbed all the shirts in her closet. I grabbed all the pants, just took quick little pictures with my phone, uploaded to PowerPoint, and put them on one of these the sheet protectors, put them all together on a clip, on a command hook, and the first thing says, Joni's closet, thanks for helping me dress myself. And every day they hand her that so that she can pick out her own clothes, because verbally she couldn't do it herself. Horrifyingly embarrassing, yes, but also reminded me that it's not rocket science. It's just about modifying tools so that communication is easier. The best tool overall is conversation and connection and communication. So I emphasize the need to be involved in groups, because I have seen hundreds and hundreds and thousands of people who have come through the door at TAP, and the first time when they go, I'm sorry, and everybody else goes, I know, I get it. Like, it is so powerful. So just to have somebody else who gets it. So the techniques, the easiest way to tell you about how to communicate, and I do a 2-hour talk just on supported communication, or supported conversation, so bear with me while I give you the 5-minute version, is these are the tools of communicating with someone who has any type of communication challenge. The very first thing is to say, I know you know. You say it directly and you say it indirectly. You say it directly by just saying, this must be so hard for you to know what you want to say and not be able to get it out. Because even if they don't fully understand that, at least they'll know you're there and you're paying attention to it. Talking to them and not talking to the spouse or caregiver. We've heard that multiple times today. Letting them know that it is not just their responsibility to get communication across. It's a two-way street. And that you're going to share the communicative burden. It's very much like they tell you when you see somebody in a wheelchair, you don't go like this and talk to them. You go to that person's level and have a conversation. Same here is that you just say, look, they're speakers and they're listener. We're going to do it together. I'm not going anywhere. And then you acknowledge the breakdowns, because if you don't, you are telling them that you don't believe that they can do it. I've seen so many times somebody communicating with someone with aphasia and they're struggling, and the person either guesses and guesses wrong. So when they guess wrong, you're not doing what they intended, so they're going to stop communicating with you. So you're really doing more harm than good by guessing. But also to say, oh, okay, I'll take care of that. And you're not going to, because you didn't understand what they were saying. So it's much better to go, I'm sorry, I'm really having trouble understanding you. Let's try this another way. You know, can you show me? Can you draw it? And we'll talk about those. The other ways are very indirect ways, which is to make sure that you always talk to somebody with a normal tone of speech, okay? You don't talk louder to someone because they have aphasia. People with aphasia will tell you, I'm not deaf, I just have aphasia. Don't talk sing-songy or down to them, or don't use materials that are childish. Now, our job is to help them reveal their competence. How can we do that? Not just for ourselves in that conversation, but for other people they're communicating with too. How can we unmask what communicative potential they do have? Well, you have a lot of options here, and a lot of them is just the supports that you decide to use with them. So getting information in, and then helping them get information out. We've heard this a couple times today, is reduce competing stimuli. These are just kind of receptive language reminders, is that you can't have a conversation when the TV's on and you're in another room. Maybe you did it for 40 years before, guess what, that's over. You're gonna have to go into the room, sit down, and have a conversation directly with them. The other thing to remember is that people with aphasia or any cognitive communication problem have a longer latency between the information that you're saying and they're hearing. And it's generally only 3 to 5 seconds. So if you think of what happens in the first 3 to 5 seconds of a statement, a question, whatever, like open the door, hand me that. What's the first word? The most, please. Whatever your mother did a good job with you. The first word in that sentence, open this or pass me this, is the verb. It's the most important part. But because a person with cognitive communication challenges are going to likely miss the first 3 to 5 seconds of what you say, start with 3 to 5 seconds of an attention getter. Okay? So start the sentence here by putting here, honey, or mom, or sweetheart, I don't care what the word you use, but coming over and going, Barb, hey, I was wondering if whatever you say after that, you have better attention. It's not something we routinely do in our age, and I grew up in upstate New York, so we just talk, and we talk really fast, and we talk from the other room. You got to stop doing all that, because that doesn't work. And then use any kind of gestures. There's a big difference between me going, hey, Mom, do you want to go get something to eat after your therapy appointment? And me going, I'm so hungry. It's time to eat. You want to go? It's just a couple little gestures that make receptive language or comprehension much, much better. Talk Italian is what. I clearly have a desire to be Italian instead of Irish, so. Refer to props and pictures all the time when you're communicating. Remember that if you're communicating with somebody without props, pictures, a pen, and paper, that literally you are providing someone who has a balance problem a treadmill without a walker. It is literally the same thing. It's about accessibility. Make sure you have tools that are in place to have the conversation. The other word I have here is keywords. Keywords is kind of sharing the flow of the conversation with the person. So you're basically going to say, so Mom, Kira's coming down because she's going to look at Elon for school, but she also has a dance competition, okay? I didn't write the whole sentence of everything I was saying to my mom. I just used the key words while I was having a conversation. I also didn't go, Mom, Kira, you know, and write each thing. I just did it natural in the progression of conversation. So if you have a clipboard and you have paper and you use the key words, they have something, you have improved the receptive communication, but then they also have something to point to talk about and ask questions for. So I can't emphasize enough that when you do key words, you're also setting them up for better expression as well, okay? And then shorter sentences, simpler structure. Does anybody remember diagramming sentences? I am such a nerd. I loved diagramming sentences. I mean, I wouldn't go sit in math class, but I love some diagramming of sentences. And when you diagram sentences, when it was complex, all of that went underneath the sentence. It was always like the main information, right? That's what you want to do. So avoid layers. Avoid saying, after we do this, before we do this. Get rid of your conditionals and just do one statement at a time. It's a really good, easy tool. The other thing is that sometimes with aphasia, one word will click, but the other one won't. So me saying I'm hungry might be hungry. What does that mean? What does that mean? But I go, I'm hungry. I'm starving now. Then hungry and starving together was enough to go pull that file of, oh, she needs something to eat. So getting the information out. This is obviously very unique to whatever situation the person is in and how much language they have. But these are kind of some general tools. One is just let them know you're there and that you're going to give patience while they go along. I think of that little card that says I have aphasia. The first thing it says is be patient with me. Allow them time. Don't fill in the words unless they ask, and encourage all language modalities. So if one isn't working, look for another one. One time I walked in my mom's room and she was clearly trying to tell me she needed something. It was like she kept going, Maura, I need. And so I wrote down, okay, you're telling me you need something. Is this something that's here or do I have to get it? And she said, you have to get it. And I just put two choices and she circled get it. And I said, okay, so what do you need? And she was trying to tell me she needed something at the store. And I said, is it something that you eat or drink? And she said, drink. She circled drink. We put two words down. She circled drink. So then I go, well, can you show me? Because I'm not having trouble. And she went like this. Going, what do you drink that you put all over your body? This is very strange. And I kept getting lost. And the reason I tell you this story is because it ended up being creamer for her coffee. Okay? Now, first of all, with someone with an executive functioning problem, why didn't she just point to the refrigerator? Because then I walked over to the refrigerator to see what she might be out of, and I lifted up the creamer, and it was hardly any in there. And she goes, that! And I go, creamer? So I wrote it down. She goes, yeah. I go, you told me it was something you drink, but then you went like this. Think about language. Where's cream stored? Creamer, cream, it's part of language, how we organize all those files. So think about that. Sometimes a person with aphasia will tell you a word that is not the word they're looking for. Don't just say, yep, that's what you meant. Instead, write it down and go, is that what you meant? Okay? Because a lot of times we guess, right? Guessing usurps the ability for the person to get that neural pathway they need. So don't guess. Instead, ask for, what's this about? You know, can you show me, try some of the choices and write at the same time. Basically, your role becomes as a narrator. You're describing to the person what you understand so far. We're not clueless. If we walk into a room and somebody's upset and looks frantic or is crying, we don't go, what's wrong? We can instead say, you look like you're upset. Can we figure out what's going on? So just slow everything down and have an exchange. And I know this sounds oversimplified, but I'm hoping we can do a couple examples. And then the most important tool is to verify that you're on the right path, so that you're doing the same thing, okay? And go back to the keywords and it's like, is this what you were talking about? So every opportunity to communicate is an opportunity to use a neural connection and a pathway. So the more communication, the better, and it's all about accessibility. You'd never give somebody a walker, but then hang it up on the wall, okay? Second part, the last part I want to talk to you about is teams. And I'm going to kind of go a little quickly through this, but I do want you to think about this, is that you're not alone, and people want to help. I remember reading the book In an Instant, which was about Bob Woodruff after he was shot, or not shot, the IED exploded in Afghanistan. And his wife was saying, people wanted to help, but I didn't know what to ask them to do. And so I kind of felt the same thing, is that people were all there in the beginning, when something happens, or families, when they know something's going on, might be offering help. What I'd like to say is, what about creating a team that doesn't, like people will say, well, they can't get therapy. So what? We're not rocket scientists. We're not brain surgeons. Somebody could come and read with the person. So I developed a program called Communication Support Teams. And basically what this is saying it was based on faith-based care models, thank you. And it was saying people want to help, but let's gather the people. And reach out to your friends and family and say, I know you want to help me, but you're not sure what to do. You know what I could really use? Could you come over 1 hour a week? And I started to formalize this, and I offer it to families who are dealing with PPA or stroke-based aphasia. And I'll say, reach out to your social networks and say, can everyone just give me an hour? And you're going to get so overwhelmed with people that will help. And then just say, 1 hour a week of just reading with the person, writing with them, reading an article, making a coffee cake together, doing something social or engaging is the communication support team. And the type of projects and tasks you do can vary depending on, you know, whatever you want. If you need some help during the day because you're working, then pick times during the day. We've actually looked at recruiting from churches, from schools, like universities that have speech pathology programs. They need to practice working with someone. They can't get hours for it, and they can't count it as clinical hours, but they love to get the experience of working with someone with aphasia. So many of the people that I work with at TAP have teams of up to 6 people that come and help them every week, and we're seeing it staving off a lot of the language-based impairments that the people get. The speech pathologist helps train the team by literally presenting these same tools of learning to speak aphasia. And then we have some tools for communication. I mentioned the other group, Facebook pages or Caring Bridge or Caring Pages. You can use something like that. But what we've done is we've used team sites. So if anyone's ever had a kid who played a sport, like a kid plays volleyball, and everybody gets on this team site, and the moms all know to bring certain snacks. Sorry, moms or dads might bring certain snacks, what days, you know, that the games are and everything. Shutterfly is one that has a team site. They're called share sites. And you could set up a Joe's communication team site. And you can literally message everybody at the same time. You can put up examples of activities, resources. It's great. And if anyone wants further information about that, I can send you the how-tos in doing that. This is how we changed the Shutterfly to be able to put resources. I even upload little videos of me working with the person so the volunteers know how to communicate with them. Because people ask, you know, how do I use speech therapy? And I say use speech therapy as a trainer. That is your personal trainer. They are your sports coach, and use it in that way. So we have people doing all kinds of things in real life because of communication support team. This is an example of a team and how you work on it, which is basically you recruit and you train them, and then you look at all the activities you want the person to participate in, which were all the ones we talked about in the beginning about their identity. And then we look at what supports they're going to need to participate in this. So if they're going to be working at the cultural center, they might need to say, welcome to, you know, Holly Springs Cultural Center. Well, they might need a script to do that, but at least they're able to participate. Maybe they can't do anything verbally, but they can help you walk to your seat or something like that. So you look at each of the activities that you've decided and then say, what communication support could I put in here to help? And the conversation we're getting about that is that people feel more connected. They feel like they're helping you. So I'll tell you that your friends are out there and your social networks are out there, whether they're people from your church, people from your, you know, neighborhood. They want to help. They just don't know what to do. So that's tools and that's teams and any, go totally. Good. Up 350, it is. Dang. No matter how fast I try to talk. Any questions? I can help now, or I can certainly stay. Sir?
But when they progress further along in the aphasia, where is the point where, I mean, does anybody know where they can no longer understand or communicate in any manner, or is that ever?
Well, those are two different things. So being able to communicate, if you think about, are you able to express, or are you getting, because most people, I would like to say that most people get more than we give them credit for. And so there is never a time, in my opinion, that you stop conversational interaction. You just modify it to the help that they need. So maybe you're doing, you know, picture books and I mean like your photo albums. I don't mean children's picture books. Maybe you're reading to them instead of them reading out loud. But to as much as they can participate in the task, you're doing it with them. So instead of them reading to the grandchild reads to them, and you do an auditory book with them. So I don't believe in ever stopping communication. Anything else? Yes. Yes. Yeah, it is a skill, and you got to keep just kind of doing it. Sometimes you'll find that you write too many words. They also say there's a certain way to write the words that people get it better. So usually with a Sharpie and just plain white paper. So line paper's more confusing, using a Sharpie, doing only the main word in the sentence. So either if it's a name or a verb is usually the ones you're doing, but you're kind of doing it at the same time as you're talking, like that skill. The other thing is that's the perfect thing for a speech therapist to teach you. So somebody was saying, well, they haven't gotten any speech therapy. I said, well, get them one session with a speech therapist, even if you have to pay out of pocket, and say, I'm bringing a couple of my friends with me, or I'm bringing my family, and I want you to show me the techniques. That's what I think our role should be, is coaching you on it, and then watch you do it, or even videotape an interaction you're having and say, can you show me how I could do this better? That's what we're good at. We're like communication coaches. Yes? Mm-hmm. There will be times where there's no verbal language at all anymore. So now you're saying receptive language, that they're not getting anything? It's hard to test. And so if you can't, because every way to test nothing going in is an expressive mode, right? Like to be able to understand what gets in, you have to be able to write it or gesture it or answer it. You have to do some expression thing. So again, I don't feel like you should ever think nothing's getting in. But what you will notice is you'll need more communication supports. So for me to get somebody to the bathroom, which would be a very simple kind of, I might have to go, you know, well, I shouldn't have picked bathroom because now I'm going to go like, you got to go here, and then show them by walking and gesturing. That's when the cognitive piece comes in. So if somebody is really just confused, they don't know where they are, you know, that's when that stuff starts to come in. So I think it's more about just keep adding more cues, and then feel like you can connect on a different level with maybe just every time you go bring a scrapbook and you do the talking. You know, as a communication partners, burden changes with the progression of this disease particularly, or for us also seeing brain tumors, is when things get worse, the communicative partner does more. So that's how I'd say it.